Welcome to the online Vitreo Retina series. Today, as part of our 6th module in VR vitreoretinal surgery, today we will be exploring a topic on scleral buckling by our senior faculty, Dr. Padmaja Kumari Rani. She is working in our LVPEI Eye Institute's Kalamanjireddy campus, Hyderabad. She is a passionate teacher and senior most academic and very interesting, and she shares lots of knowledge and trains many students, fellows in ophthalmologists. So without a further ado, we welcome Dr. Padmaja Kumari Rani to take over the session. Over to you, Doctor.
Yeah, thank you, Lokesh. So today we will discuss the steps of scleral buckling. So the scleral buckling is a primary gold standard modality in terms of repair of primary rhegmatogenous retinal detachment. So we will look at what are the preoperative steps, intraoperatively what are the steps that you need to take care whenever you do a buckling surgery, and then scleral buckle steps as per se. So preoperatively, it's very important what is the selection of the case, and we'll go one by one into the steps. So preoperative selection of case is the most important, and positioning of the patient for the buckling surgery is again another important consideration one should keep in mind. And preoperative drawing and planning is almost is equal to almost 50% of your surgery. So your preoperative planning for surgery is the most important. So when you look at the selection of the case, any fresh retinal detachment, PVR grade up to C2, that means 1 or 2, one small fixed fold also can be done buckle if there is other vitreous attachments and everything favors with the buckling case. Old retinal detachment with subretinal gliotic bands, intraretinal cysts, that means where you see a subretinal PVR changes, that is the case for buckle. Then break, whenever you look at a big retinal detachment case, it's very important to know the size of the break and also the location of the break. And the location of the break is the most important. And whenever you see, and also the type of the break. So whenever you see a retinal detachment, you need to appreciate, is it a break which is either a retinal hole, or is it a lattice with hole, or it is a horseshoe tear? And also the location, is it at the from the ora around 2 mm, or from the near the third artery vessel, or near the second artery vessel? So these are very, very important. One simple tip is the smaller the break and the difficult to see the break, easy to close with the buckle. Something a break which is very easily seen, and it is very difficult to close with the buckle. So, and then retinal dialysis is again another important indication for buckling surgery. Media clarity is important, and then any fresh retinal detachment and how is it, and positioning of the patient before the surgery depends on the macular status. So it's always we should try to keep the retinal break in dependent position so that the fluid drains on its own, and also it improves the visualization in case of any mild vitreous hemorrhage. As I said, preoperative drawing and planning is the most important. So indirect ophthalmoscopy with the scleral depression is the art everyone should follow meticulously. And then the buccal drawing and planning will help you to master this art of buckling surgery. So what are the clues that when we see a retinal detachment that can give you that the localization of the break, pre-op localization of the break? So if there is a break which is, for example, at the highest bulla, whenever you have a subtotal RD or anything, wherever the highest bulla, that is where nearest to the location you can suspect a break. Similarly, if there is a inferior retinal detachment, so you can expect that the break could be around 6 o'clock on either side. So that's how these are the rules that can help you. But all this can be mastered only by doing indirect ophthalmoscopy and scleral depression. And then next thing is very important to have a very good drawing. And when you say drawing, buccal drawing, it is important that you actually localize draw the vessels, the veins we draw, not the arteries, until the buckle break location and all around. And this kind of a detailed drawing will help you not only to know the nature of the detachment, the type of the break, and then also localization of the break and the landmarks and the vitreous attachment. And that will help you to determine how you are going to do the buckling surgery. Intraoperatively, it's very important that, for example, positioning of the patient, like for example, if you are having an inferior break, slightly keeping the chin elevated will help you to localize the break much more easier, and also place the buccal sutures easily. Anesthesia, yes, initially when until you master that, maybe a general anesthesia is a little preferable, because buckling surgery might take an hour or 1.5 hours. So it's very important that the patient is cooperative, and so general anesthesia is not a bad idea when you start your buckling surgeries. Then the sterile buckling draping, the position of, as I said, try to keep the patient eye in the primary position so that you can localize the break appropriately. And anesthesia, one more important is to keep in mind when whether it is a local anesthesia or general anesthesia, it's keep in mind in your ear to the heart rate. Because sometimes when you do the tagging of the muscles, or when you pull the muscles, there can be sometimes a bradycardia, and which is due to vasovagal reflex. And this, if you keep your ear on the monitor, you can hear that if there is a sound dip, you know that there could be a vasovagal reflex and bradycardia, and you can actually supplement with a xylocaine. And definitely you should have a caution in highly myopic eyes where you do the local anesthesia. Here is some of these pictures are from Shankaranathala, where I learned my buckle art initially. So here it is not, the idea is not to show you how I'm looking at that point of time, but it is mainly to show that when we are doing buckle surgery, actually the field should be all around, should be free, so that you will be able to move around easily. The buckle draping need not have too much of surrounding analysis, so that you should be able to move freely around the patient to identify the breaks and do the thing. So now let us look at the steps. The steps are, first step is the conjunctival opening, then we do rectus muscle tagging, then we actually do the quadrant check, then the most important is again localization of the break intraoperatively, and then the retinopexy, the break we need to localize, and then we actually do localize the treatment of the break, either mainly by the cryotherapy, and then placing the buccal sutures. Then you have scleral tunnels, then you place a scleral buckle, then you can place a belt buckle band, and then you do a drainage of the procedure, if required, a subretinal fluid drainage and conjunctival closure. And all these steps are very important, right from opening to closure, need to be meticulously planned. So let us see in this video, these are all the steps. The first thing is the conjunctival peritomy, and then you are doing the muscle tagging. And after the tagging is done, then you do the check. And then these are the placing of the buccal sutures. And you can see horizontally you are placing the sutures, and anterior bite will be there. And you are placing the buckle. And you're trying to do the drainage by the choroidal thickness, and then one can actually cauterize things, and then you are actually, with the needle I'm draining. So one can do either drainage with the needle. And once you drain, and then you actually press on either side so that the fluid comes empty. And you make a 3.5 mm. If at all you require some saline injection, if it is required, you place it. And then you tighten the buccal sutures. And then meticulous closure of the conjunctiva is very important, because here you are leaving a material permanently in the eye. So the conjunctival closure opening, Usually I do around the limbus and then cut, but sometimes if you have any glaucoma related, some bleb or something is there, one can actually do a posterior peritomy and then do a continuous closure. So the muzzle tagging, again, it's very important that you don't tag muzzles, inadvertently double tagging or, or split the muzzles. So it's very important to check after tagging the muzzles, is it complete, by looking with the retractor. And then quadrant check is again very important to see any thin areas of thinning, especially the sclera. For example, the scleral thinning can appear like a bluish areas in those areas. Accurate localization is the most important, the key for the success of the scleral buccal surgery. So how we do localize is that you, as I said, preoperatively only, you will try to see whether the break or location, for example, a break is located from 3 mm from the aura when you are seeing the fundus, you want to accurately localize it. So how you do localization is, this is the TLAX, spiral of TLAX, that is the insertion of the muscle. From that point, you either with a localizer, or sometimes I use a tooth forceps, but anything we need to make sure the localizer is good, because it will have a blunt end, so that the chances of poking or anything, and one need to be gentle enough to indent the localization of the break while seeing through the indirect ophthalmoscopy, and you make a mark of it, and that mark on the sclera, when you make it, you actually measure it from the insertion of the muzzle. So for example, if it is around 5 mm, you know that you need to place at least a 2 mm extra width. That means a 5 mm break can be managed by a 7 mm width buckle, or if it is 7 mm, it is a 9 mm width buckle. So +2 is the rule. For example, if you have a large single HST, how do you localize? Is like a 3-point localization. So you localize the most posterior most portion of the break, and as well as the anterior two ends. And then the way you place buckle is, you kind of place the buckle in that area. Similarly, if it is a dialysis, it is a two anterior borders. That is what you will localize. And if there is a significant posterior extent of dialysis, even the posterior most point should be localized to keep the buckle. For example, here you can see the buckle placed drawing. You can see that there is a 276 buckle has been placed, and these are the tunnels made for the 240 band. If there are multiple lattices, the posterior most lattice is what you will look for, and that is what you should be localizing. So you can see this ends, if they're at one level, both anterior lateral margins to know the extent of the buckle. Posterior margin is mainly to know the width of the buckle. Break, one few things that we need to understand is that the breaks will always look like they're looking posterior than its true location. So some of the things that might help you is there any pigmentation or the anatomical landmark may help you to know when you actual localization during the surgery will help you to know the actual localization. That's why it's very important that because of the parallax error you might feel. And it's very important to stand exactly in the opposite quadrant rather than to know the true localization of the break. And it's good to start indent anteriorly in the meridian of the retinal break, flatten the retina, and then localize it. So people describe techniques like days, that is you drain and then localize in case of bullous detachment. So far in my career, I might have done many buckles, but I never had to resort to the technique of draining the fluid and then localizing. Presence of pigments at the level of RP and all, they can give a clue where the break might fall once it is settled. So, and indirect clues for the localization, it's always important to keep the landmarks like presence of pigments, distance from vortex veins. Vortex veins is actually anatomically, it localizes for you to the equator, right? And then distance from the aura and distance from the arcade. So the simple clue is when you see with the 20D lens, the retinal break, in a shallow detachment, the break is likely to be there where it is supposed to be. In a bullous detachment, they may appear posterior, but it may not be really posterior. That's why it's important. So the indirect marks, like for example, how far it is from the ora margin, or how far it is from the second order vessel, how far it is from the third order. So anything from third order and beyond is always a case which can be done buccal. So it's very important. That's why the localization. So it's very important for you to, when you do these drawings or when you make a selection of the case that this is buccalable, these aspects should come in play. And also the vitreous separation. For example, there are 2-3 HSTs are there, horseshoe tears are there in the superior 12 o'clock meridian. And you know that horseshoe tear means it is a case of a retinal detachment where the vitreous is completely separated. So sometimes it might be much more easier for you to do a vitrectomy in those cases, because you might be missing any other HSTs, or it because the vitreous is completely separated. Sometimes the buckling surgery could be little tricky. I'm not saying that the HST is a contraindication for the buccal surgery, but when you see a HST inferior, of course you can, for example, there is a single HST inferior at 6 o'clock. You can always go for buccal. I'm not saying that you cannot do it, but vitreous separation also play a very important role. So an young patient comes with multiple lattices, 360 degrees, and there is a posterior most lattice you could find around 7 mm from ora at 6 o'clock. I would go for even a 4-quadrant buccal. It doesn't matter. It's all required is 8 sutures to be placed in a patient, because there is no separation of the vitreous, completely adherent vitreous. And a young boy, for example, a 12-year-old, it's always a buccal is a straightforward choice. Similarly, some 16-year-old patient who comes with high vitreous complete adherence, then again a buccal could be a choice. Retinopexy could be diathermy, laser photocoagulation, and very important that cryo is the most commonly used. But very shallow detachments are, for example, if you have a fundus picture where you have in attached retina some lattices and there is a detached retina, there is a break, you can finish off attached retina lattices by laser, so that you are actually reducing the amount of retinopexy trauma. And indentation with the cryo tip is more important, because initially the cryo tip, when you are holding, it can slip and there can be an inadvertent posterior cryo reaction. So that's why it's very important to keep the cryo tip exactly perpendicular to the break is very, very important. So when you keep it perpendicular and indenting with the tip rather than the shaft, this will avoid the step of posterior thawing. And then confluence. Most important is avoid keep refreezing and all. And also important is when you see a cryo reaction inside the eye, it's very important not to allow it to gentle thawing, and rather than just removing the cryo probe inadvertently, because that can cause, sometimes what will happen is it can happen create a linear new breaks, and then you might find that you initially you had a difficulty in identifying one break, and after that you find that there can be new breaks, linear red color appear, the blood can appear, and then so it's very important to avoid sudden lifting of your cryo probe. And then end point is gentle whitening, and no, don't freeze the bare RP, because it can cause the unnecessarily reaction of the release of RP pigments and then ERM formation. As I said, width 2 millimeters anterior and posterior to the localization point, and breadth at least 3 millimeter lateral clearance. So we have different types of buccal, but most commonly we use the silicone, solid silicones, and sponges. In previous days, when the vitrectomy was not so much prevalent for posterior breaks, it had been used, but nowadays it is not so much in common preference. But the buccal configuration, asymmetric tires, more buccal height posteriorly, And usually the choice of here is usually 276, which is actually done for dialysis. And the buccal sutures, as I said, the anterior buccal, you take the anterior suture and then posterior coverage. And this posterior coverage, for example, if the break is around from this muscle insertion, if it is around 5 mm, you keep a buccal suture at 7. The buccal width is around 7 mm. So you actually take the posterior bite 9 mm. So that is very important, simple rule, 2 plus 2. So if the break is at 5 mm, you choose a buccal which is +2, that is 7 mm, and you take your posterior bite as 9 mm. Similarly, if the break is at 7 mm, you choose a buccal width which is +2, that is 9 mm, that is around 279, and then you take the posterior bite at 11 mm. So the tunnels are made in each quadrant, and then you place the SB placement. As I said, at least 2 mm coverage one should keep in mind. And then placement. Then the BB placement we do mainly, it's like an artificial aura creating, and it supports the vitreous base. And the buccal refraction also, one should keep in mind that it should not be crossing the indent, or the tightening of the belt or buccal sutures should not induce more than 1.5 to 2 diopters. And this is something you should watch over your buccal refractions, which you usually can take as a final at around 3 months' time. That's something you should keep in mind. So management of subretinal fluid. So when there is a shallow detachment, when the break is flat on the buccal, you need not go really for any subretinal fluid drainage. Or superior breaks which are minimally lifted from RP, or where the cryoreaction is more seen, you need not really go for it. But when there is a highly elevated detachments or chronic inferior detachments, PVR, this thing, RG, glaucomatous eyes, breaks which cannot be identified, elderly patients, eyes with multiple breaks, high myopia, you can go for subretinal fluid drainage. So the drainage can be done outside the bed of the buccal or within the buccal, and the are most important size that you can also choose for preference of instead of, because this is the only drainage which is a blind procedure which can cause complication, is the subretinal hemorrhage. So you can find actually the least vascular preferred drainage sites are on either side of the rectus, where the choroid is the least vascular. So the needle drainage can be it can be done with needle or endolaser probe or cautery. Drainage can be inside or outside. As I said, the site of the maximum fluid like a bulla or a subretinal fibrosis or a tiny fixed fluid, those are the good places to drain, because the chances of any retinal incarceration, those things are very, very less. As I said, stay close to the horizontal meridian when you want to drain. That is the best. Better exposure will be there and less vascular choroid will be there. Avoid draining directly over the break, because sometimes it can cause a vitreous also can come. And how to minimize complications is, especially if there is a very IOP high, sometimes bullous retinal detachment, you can find a retinal incarceration. And if it is IOP is very low, then again it can have an inadequate. So sufficient length, the sister should be holding very nicely, holding the buccal, and recheck for the presence of any large blood vessels under to prevent the subretinal hemorrhage. So, for example, when you are draining and suddenly if you see that there is no fluid or sudden stop of fluid, don't keep on poking, stop. Close the sclerotomy, visualize, and if there is a fluid is present, inadequate, then you can think of if the IOP is low, you can inject and then you can try. But very important not to go on poking the thing. So if there is iatrogenic break or through existing break, or the vitreous loss, or if there is any, so you can excise the prolapse vitreous, close the sclerotomy, cryo. And if the break is happened due to localization, during drainage outside the bed, then you can put another suture and support that. So the conjunctival closure, as I said, is the most important, where you can actually, I try to close both tenons as well as the conjunctiva. So the tenons, I try to close I take an episcleral bite near the muscle insertion, and then close posteriorly on like an anchoring, and then again the conjunctival closure at the limbus. So the secret of the success story of the buccal is good localization and treatment, and then proper selection and placement of the buccal and uncomplicated SRF drainage. So I'll just show one more presentation. Is my presentation seen?
Yes, doctor.
Okay. So it's very important. Many times we have a dilemma, what buckle to choose and with what. So for example, this is a 24-year-old male phakic patient, one-eyed patient. And you see that he has already underwent some laser barrage. And actually the break, the primary break, which is causing this detachment, you can see that the laser barrage and then the break, the retinal detachment is crossing this laser barrage and is extending to the macula. And the primary break is actually just when we localize it is only 5 mm from vora. And as our rule, we know that we need to keep at least 7 mm width buccal. So we took a 287, which is a convex buccal, which will give a good indentation. And this is the post surgery. So you can see that the retina settled very nicely. We did a drain also inferiorly at the near the inferior rectus. So the location of primary break is important. What did we learn from this case? Convex buccal is preferred to cover even any tractional component. And posterior laser barrage marks are not a contraindication for doing this in this patient of a high myope with a one-eyed patient. Now let us look at this scenario, 18-year-old, one-eyed, phakic, high myope. You can see other eye due to spontaneous retinal, and this is the retinal detachment. You can see we show shallow detachment that you could see this. So what I planned was I took a 276 buccal, which is around 5 mm, 7 mm width. And then because there were no clear-cut breaks, so I did inferior 2 quadrants was a detachment. So 276 buccal, inferior 2 quadrants, 4 sutures, suspicious areas were cryoed, SRF was drained. And this is fantastic. You know, the retina nicely attached. So what did we learn from this case? No visible break is not a contraindication. So in a case where in a high myope, 18-year-old, one-eyed, phakic, and where you know that the vitreous will be completely adherent and vitreous is not separated, so end-to-end buccal with suspicious area of coverage can solve the problem. Now let us look at this 25-year-old male phakic patient, and you can see multiple breaks here. And localization, all the posterior most break is what you will localize. This is the posterior most break. So this was 5 mm from vora. Okay. So now I choose again a 287 because I suspected that there is some amount of tractional component. They're like, you know, lattices which are with the holes in that. And then we have done nicely this thing. So multiple breaks are not a contraindication, and actual localization of posterior margin of posterior break is important. Now let us look at this scenario, 49-year-old male, phakic, and you can see this is the break. And the localization was 7 mm from vora. So when it is 7 mm from vora, we want to put 279 because you want at least 2 mm coverage of the width. 279 is 9 mm width, and you take sutures at 11 mm, and you see the beautifully the buccal which is attached to the retina. So break localized underneath the muzzle. So one suture, if whenever you have a break which is localized underneath the muzzle, you have to take one suture on either side of the muzzle. So this is the simple rule. If it is 7 mm width buccal, that is either 276, 277 or 287. Posterior bite will be 9 mm from vora. If it is 9 mm width buccal, that is 289 or 279. Posterior bite will be 11 mm from vora. Only very rarely you might do a 280 buccal, that is 10 mm width buccal. That means a break which is around 8 mm, or then only you will go for this. So 10 mm width buccal, posterior bite has to be 12 mm from vora. So 2 plus 2 plus 2. Now, this is a 21-year-old female, long-standing retinal detachment. In fact, this patient was moving around with the ophthalmologist. Multiple lattices were there in 3 quadrants, and posterior lattice was localized 5 mm from ora. And this patient was actually going around with MRIs and neural because no one has suspected a retinal detachment without seeing the fundus. So indirect is very important. So 287 buccal was chosen and was done in 3 quadrants. So that what I'm trying to say is that if the lattices are there in 3 quadrants, if you just fix the 3 quadrants, then you SRF is drained and you see very nicely the retinal detachment. And you can see the fellow eye also has a inferior detachment which was detected. So it's very important to do the fellow eye examination and any localized RDs and which may require the attention. So accurate indirect ophthalmoscopy of retinal periphery of affected and fellow eye is must. Multiple breaks in multiple quadrants is not a contraindication. Anytime once you learn a buccal art, what all the buccal need to be done is maximum 4 quadrants and 8 sutures is all required for a buccal suitable RD. So in a buccal suitable RD, we should not hesitate to go beyond 1 quadrant, 2 quadrant. It's not like we can only do 1 quadrant buccal, 2 quadrant buccal. If that is a required and it is an indicated case, you should be able to go for 4 quadrant and 8 sutures is all required for a buccal suitable RD. And this is a case scenario of 31-year-old male, phakic, high myope. And you can see this break, which was, when we localized, it was 8 mm from ora. So what we have done, 280, and it's a high myope. And you can see the break is nicely flattened the buccal, and it was a non-drainage, and then retina settled. So actual localization of posterior margin of bronchi is important. Morphology of RD, understanding posterior vitreous detachment status, chronicity of RD, subretinal PVR changes like demarcation lines, intraretinal cysts, buccal is the choice. This is a 24-year-old phakic, very shallow detachment. And I could not identify a clear-cut break. Suspicious dialysis was there in a superior nasal granule, non-drainage, and I chose a 42 band, and the retina settled very well. So no visible break is again not a contraindication. IOCT can accurately identify the extent of detachment. Linkoff rule can help to identify the suspicious break. For example, the detachment is there somewhere in the superior nasal, one can suspect. Then this is a 52-year-old phakic, and you can see extreme scleral thinning, and the break was 3 mm from the ora. And then I actually placed a 42 band over the break, and then they did the this, and then you can see that extreme thinning you can appreciate. And with the 42, it was actually settled very well. So extreme scleral thinning, careful suturing can be done to secure the buccal of choice. Thank you. Any questions are there? Hello?
Hello.
Okay. Okay then. Okay. So can we then finish? So you will be knowing if someone is there actually, Ritesh? Ritik? Okay. Okay then. Thank you very much.